All right, everybody, good evening. Welcome to our all hands call. Joining us this evening are some of the most influential thought leaders from the health insurance sector. We have with us Mr. Anurag Kumar, Ms. Malti Jaswal, and Mr. Birendra Mohanty, who will be discussing health insurance for India's missing middle. The call will begin with Anurag taking us through a paper he co-authored while at NITI Aayog last year, followed by a fireside chat with Ms. Jaswal and Mr. Mohanty. Now, the primary purpose of this report is to recognize the policy issue of low financial protection for health in the missing middle segment. The report highlights health insurance as a potential pathway in addressing that and in improving the efficacy and quality of the healthcare that is delivered. In doing so, the report offers a starting point for broader discussions on solutions, specific products to improve insurance coverage for the missing middle. The report envisages a wider industry and government stakeholder consultation, as well as discussion with consumer groups to delve deeper into specific components of the problem, as well as posing a potential path ahead. Before we delve into the call, a note for the attendees. We do hope to accommodate all questions and questions that you might have. Please do either of the following. Type your question in the Q&A box, which will be activated, or raise your hand. We shall try to accommodate all questions. In case we are not able to, you can always mail your questions to us at the email ID that has been provided, which is allhands@swasthab.org. Before we begin, I would also like to briefly introduce our speakers for the day, starting with Anurag. He currently works as a health economist at the World Bank. Prior to this, he worked on health financing and economics-related policy issues at NITI Aayog. His interest areas include financing mechanisms, public policy formulation, and the role of the private sector. He holds an MPA Economics and Public Policy from Princeton University and a BTech from IIT Delhi. Thank you for joining us, Anurag. Next, we have Malti ma'am with us. Malti Jaswal has worked in the insurance industry since 1986 and has contributed to setting the foundations for health insurance in India. During 2014 to 18, she served as the Chief Operating Officer with the Health Insurance TPA of India. In 2018, Malti ma'am joined the World Bank, where she has worked on ABPMJY as a senior consultant since. She developed a diploma certification course on health insurance for the Insurance Institute of India. She's also a member of the Health Forum of IRDAI and also led the IRDAI NHA Joint Working Group on Fraud and Abuse Control. Thank you for joining us, ma'am. Finally, we have Birendra sir with us. Birendra is an insurance professional with over 21 years of work experience. He is an associate of insurance from the Insurance Institute of India and currently heads distribution practices of ICICI Lombard GIC, India's second largest insurance company, where he is currently responsible for agency and SME. Thank you, sir, for joining us. With that, I hand over the floor to Anurag. You may begin. Thank you so much.
Thank you, Shivangi, and thank you to the SWAS team, Ajay, Urvi, for having me. I think sort of the organization of our health system or our health sector in general is one of the most important issues sort of as we look in the next 10 to 20 years as a country. So anything which deals with how it's organized in terms of the purchasers, the providers, the regulator, and most importantly, the patient, discussing that and arriving at solutions is very important. So thanks for organizing that in that context. Before I get into it, I think just very quick two disclaimers. As you've already mentioned, these views are my own. They're not my current employers, World Bank or of NITI Aayog. Having said that, this report is a Government of India report, which was prepared when I was there. So let's get into it. Next slide, please. So the idea is basically I'll outline some key messages which came out of the report. And in doing so, I'll start with a bit of the background and context why we're talking about this. Then what does the current health insurance landscape look like? What are some of the characteristics of the people who we think are not covered? And then really get into the solution space and potential pathways, right? What would such a product be? What are some of the key challenges? And what are some of the solutions that we can think of? And then really get into discussions and questions with Malti and Birendra, who know about this much more than I do. So I think so we leave more time for the most interesting part. So next slide, please. So in terms of background and context, right? Why are we talking about it? So if we look at India's health financing landscape, the government spending on health, both in absolute terms, is quite low, and as a share is around 1/3 of the total. Now, this obviously has implications in terms of the capacity of the government providers to deliver. You see overcrowded hospitals, etc. But what it also means is that most of the spending, around 2/3, is private. And not only is it private, it's mostly out of pocket, right? So most of the 2/3 private spending is almost all out of pocket. If you see sort of the chart to the right and the dark blue line at the top is India, you'll see it's been persistent around over 60%, 60 to 70% over the last decade, which is higher than the lower middle income country average. It's higher than the middle income average, and it's higher than the global average. And what that means is, and sort of all of this out of pocket expenditure is with private providers predominantly, right? With an unclear link to what kind of outcomes are being provided, what kind of quality it is. So that's why this is something that we really need to think about. So why health insurance, right, in this context? So two things, right? One, which I think everyone knows and recognizes, is that it provides financial protection from health shocks, right? You pool funds, so you're cross-subsidizing from the healthy to the sick, from sort of the young to the old, et cetera, et cetera. I think the second point, which is a little bit less appreciated, but I think is quite important as we think about more outcomes in the organization of the system, is that when you have an insurer, or when you have sort of a consolidated pool of funds by a purchaser, instead of individuals going for consultations, going for discrete things at the hospital, it improves efficiency of spending, right? Because then you can negotiate packages, you can avoid wastage in terms of doing the same test twice at different parts. So, and those are the kinds of provider consolidation and sort of improving efficiency of spending, which a purchaser can provide. So these are the two fundamental reasons why health insurance can be one step in pathway. It's not the only thing. The government spending increase is super important, but that's sort of the context in which to frame this conversation. Going to the next slide, please. So just to say, I mean, again, in terms of financial hardship, which is one component of financial protection, different estimates, but around 5 to 9 crore people go into poverty from out-of-pocket expenditure on health. Around a quarter of the population spends more than 10% of their household income on health. And of those who access healthcare, almost 60% end up paying more than 10% of their household income on health. And these are huge numbers, because it's not like the first 3-4 quintiles have a lot of disposable income. Next slide, please. So what does the current insurance landscape look like, right? Who is covered, who's not covered, what are their characteristics? Next slide. So currently, you can think of the health insurance landscape as basically there's 3 broad kinds of provision. The biggest chunk is government subsidized health insurance. And this is eligibility, not necessarily a coverage, and I'll come to what that means. Around 50 crore people are covered by ABPMJY, which is the centrally sponsored scheme, right? This 5 are eligible, sorry, which is the centrally sponsored scheme, the 5 lakh per family covered. Then in addition to this, there are around 20 crore which are eligible or covered under state extension scheme. So these are states which choose to extend either the number of people covered, and sometimes they also expand the benefits package. So you have around 70 crore people who are in principle eligible for government subsidized health insurance scheme. Then you have around 14 crore people who have social health insurance. So in this, the biggest chunk is mostly the employee state insurance scheme, which is for formal sector workers earning less than 21,000 in firms of a certain scale, right? So this, the employer pays and the employee pays a contribution, and then they get access to some services. And then the third chunk is private voluntary health insurance, which includes both group insurance and family insurance, basically the retail product that you buy, which is around 11.5 crore. So if you add these up, it's around 95 crore people who are either eligible or covered with health insurance, right? Which leaves around 40 crore. Now, 2 things to highlight. One, sort of, this is a mix of different insurance schemes, obviously, and the benefits packages are very different. So it doesn't mean everyone gets covered by a same set of benefits or has access to the same quality of care. Most of them have no PHC or OPD benefits except ESIS in principle. The second thing is actual coverage might be lower. It might be around 50% instead of 70%. And this is because of gap in eligibility and coverage in the government subsidized insurance schemes due to a bunch of reasons, potential overlap between different schemes. And the final point is we're talking about coverage or eligibility, but there's also this point to be noted that that doesn't necessarily translate into access and quality of care, right? That doesn't mean that you're covered, that you necessarily have the places to go, and because there's also a supply side dimension to it. All right, so I mean, either way, if it's 40 crore, if it's 50 crore, it's 60 crore, there is a large number of people who are uncovered. So who are these people? Next slide. So normally the way that we think about the missing middle, or it's been conceived, is sort of to the left-hand side, right? Is that there is a poor, which is covered by government subsidized health insurance. Then there is a relatively rich, which is covered, which is mostly formal or organized sector, covered by private voluntary health insurance and SHI, and the missing middle is somewhere in the in between, as the name suggests. But in reality, it's much more of a triangle or a diamond with sort of it being spread across different income categories, but really concentrated in that third to fifth income quintile is sort of how you would actually think of it. And so the idea is just to say that the missing middle refers to a diverse, it's not a monolith, it refers to sort of a broad array of groups, and some of them will have some financial capacity to pay based on where they sit. Next slide, please. So just broadly in terms of where it's spread, and this is sort of a lot of number crunching and then some sort of estimates based on NSSO data. But just to say that it is spread across rural and urban areas, an estimated 27 to 35 crore individuals in rural areas, 11 to 13 crore in urban areas. In the rural areas, they would be predominantly self-employed in agriculture or self-employed in non-agricultural activities, and then a few who are wage earners. In the urban setting, it's much more diverse. It will be formal, semi-formal, and informal sector, right? So you can think of people in the formal sector very clearly having an ability to pay, but they feel that they don't get any value out of it, or it's just not worth it, right? You can think of a lot of young people. Then there are people in the semi-formal and informal sector where probably awareness is sort of a bigger concern. And these could be everyone to people working in your household. They could be people sitting in small shops. They could be painters, welders, plumbers, etc., etc. So just to say, it's spread across rural and urban areas, income groups, and a diverse area of occupations. Next slide, please. So yeah, we know sort of how this problem is framed now, why it's important, what are some of the characteristics of the people who are not included. So let's get into the solution space and potential pathways, where we can go from here. What are some of the things that we need to think about? Next slide. So there are three fundamental elements that we thought of while thinking about the solution. The first is the product, right? So the first question to ask is, all right, so what kind of benefits are we offering and what will be the cost of this product? And this wasn't something that sort of came up more theoretically. This was a working group which included a lot of different insurers. It included a lot of private sector participants, and it was based on those discussions in terms of what might be feasible. The second is then, who is the insurer or purchaser, right? Is it predominantly through private commercial insurers as a contributory product? Should government purchasers, ESIC, or the National Health Authority play a role? And the third is the financing agent. Will it be affordable to the private customer, or whether partial or full government subsidy may be required? So these are sort of the three broad blocks to think of as we move into the solution space. Next slide, please. Right, so existing private voluntary health products are a bit expensive. For example, for a family of 4 to 5, they would be around 12 to 24,000. If we think of the affordability of the missing middle, this is around 2 to 3x that price point, right? And we'll get into a bit of how we came to that a bit later. So what does, and then we think of, all right, based on these discussions that we had in the working committee, what does a product look like? So there were two things which were clear. One is standardization and simplicity, right? That health insurance is a complex product to understand sort of for anyone. There's exclusions, there are waiting periods, their deductibles, their co-pays. It's not an easy thing to understand. So you need some sort of standardization of benefits and simplicity. So there's a broad idea of these are the kinds of things that we will get, and then to have paperless and cashless coverage, etc., to reduce that complexity. The second is in terms of affordability, which we talked about. And for an IPD product, 4,000 to 6,000 per family per year, and around 5,000 for an OPD sort of subscription model is what would seem to make sense from these consultations. Next slide, please. Right, so in terms of the product itself, right, and first we'll focus on the IPD or the hospitalization part of the product. There's already something which IRDAI launched called Arogya Sanjeevani, which aims to create a standardized product with a defined minimum benefits package. It's hospital cover only, but it just says that this is the waiting period. These are the set of benefits. These are what is excluded. These are the limits. This is the copay. So it has the sum insured is flexible depending on need, but it gives some structure that irrespective of where you buy it from, this is what you're assured. Now, the subscription to this has been quite low. It's less than 1% of the entire private voluntary health insurance market. And that could be due to a variety of reasons. So we think like that's a good start. The proposed product would probably should have lower waiting periods, and then consider instead of fee for service, some package rates to maybe reduce the overall cost. But that's something that it can build on. There's more details sort of what the product is proposed in the report, but that I think is the starting point. Next slide. So then, and this is, I think, a very important point is in terms of having OPD cover. I think that for the missing middle, having an OPD cover would be quite important. Obviously, it's easier said than done, but for two reasons. One is to reduce catastrophic health. So basically for all your financial hardship and financial protection. And the second is to increase the product's uptake. And this is because of the following reason, right? For people who incur catastrophic health expenditure, so for people who spend or households that spend more than 10% of their sold income on health, almost 80% do so on outpatient and around 40% do on inpatient. It's greater than 100 because some people do it on both. So which basically means that people who are affected or for whom financial hardship occurs due to health, OPD expenses are much more salient than IPD. And secondly, only 3 to 4% of people have an IPD visit every year, right? Maximum 5%, whereas OPD visits are much more common, around 2 per person per year. So the perceived value of the product increases if you're at least utilizing something. And then again, this point, which relates to what I started with, integrating IPD and OPD can also lead to overall efficiency, right? Reducing cost, improving outcomes. It means that, again, you're not repeating the diagnostic tests. You're thinking about treating at the right level. You're going to the clinic or the GP instead of the hospital. There's some more incentive alignment between the different providers. And then there's some sort of initial skeleton of what could be an OPD product. Next slide, please. So now coming back to this 4,000 to 6,000 number and 5,000 that we had discussed, one way to think about what is affordable is to look at what is the current average out-of-pocket spending that a family of 5 would do, right? And we look at it both in urban and rural areas in the 3rd to 5th expenditure quintiles, assuming that the first 2 are mostly covered through government subsidized health insurance. So you can see sort of the red box shows that around 2,500 to 6,500 is what on an average a family of 5 would spend on out-of-pocket expenditure on IPD. So then this 4,000 to 6,000 premium makes sense. Obviously, your willingness to pay will be much lower because not everything is covered. And on outpatient, similarly, the spending is around between 5,000 to 10,000. Now, again, everything won't be covered. So 5,000 seem like the base and seem like a good starting point. But just to say that this is what they're already paying on an average. So there is affordability in that sense. Now, what the willingness to pay is what we'll get into sort of during the discussion. Next slide, please. Then in terms of the challenges, right? So there are 3 challenges, which I think we all know, but just sort of to outline them and then think about who has to solve these challenges. First is awareness and confidence in health insurance. Paul discussed it. Insurance is a complex product. You pay for it in the hope to not use it, which is sort of not a very intuitive way of spending, right? So a lot of consumer education is required to increase uptake. And this is the role of both the government and the private sector, in our opinion. The second is to build confidence in existing products, right? If we have good grievance redressal, then you have a lot of word of mouth, and then sort of that also improves the uptake of the product. Now, this is the role of the regulator in terms of the enforcement, and the role of the private sector in terms of sort of delivering what is promised. Then the second is reducing the cost for affordability. And this is about one, reducing distribution and operational costs, which around 30 to 40% of the premiums sort of go into distribution and operational costs, right? So, and so leveraging digital channels for distribution, can we think of improving operational efficiency in claims processing? These are two things to think about. And then when we have these IPD, OPD integrated models, then we can also think about more efficiencies which reduce costs further. And the final point is sort of a classic health insurance, voluntary health insurance issue is of adverse selection, which is basically the sickest people enroll, which means the premiums keep on going up as healthy people opt out. And then conversely, preferred selection, which is then insurers would want to exclude some of the riskiest people or to price them out, and then sort of that defeats the purpose of health insurance. So look, the only way out of this is to have a large diversified risk pool. And then it's thinking about what are some of these formal and informal groups that we can address, and what has been the success, what have been the challenges of it, right? Vendor associations, self-help groups, et cetera, to diversify the risk pool, which can also then bring down the cost, because then you're not subsidizing because you're reducing adverse selection. So it's also bringing down the cost, which goes to point two. So wrapping up, I think, next slide. Then what are some of the potential models, right? As we think about this, what are some of the potential models? So going back to the framing of this, if we think on a 2x2 scale, the government or a private purchaser or agency, and then who finances it, whether the government or the private individuals finance it. One model is to expand fully subsidized coverage to part of the missing middle through PMJAY. You basically expand it. This is completely government financed, government done. The second is that the existing network, so the National Health Authority or ESIC, introduce what they offer as a voluntary product, right? So in the case of ESIC, it would be their medical benefits, which are offered as a voluntary contributory product in addition to what they currently do. In the case of PMJAY, they can offer their existing product to people who want to buy it, a PMJ Plus, which is on the lines of a proposed product. So this is privately financed, but government purchasing. And the third is what we talk is then the private insurers sort of offering this modified Arogya Sanjeevani product with OPD. So these are the three sort of broad things that we think about in terms of expanding insurance coverage. And next slide, which is the final slide. Then how do we think about it, right? Perhaps in terms of a time frame. In the short term, maybe we think about and see whether this expanding private voluntary insurance through commercial insurers work, essentially this product which we've talked about. And then the role of the government and the private sector is building consumer awareness, offering this product, having large group enrollments to sort of build large diverse risk pools and increasing the affordability. In the medium term, we can think about opening up NHA, PMJAY, and ESIC to offer a voluntary product. Now, the reason why hurry into doing this is that there are already a lot of challenges in terms of utilization of PMJAY and ESIC on the supply side to start with, and on the demand side. So you don't want to add on more things to their existing mission without sort of the core function being strong. And so this is something which once their core function stabilizes is something that can be and this will, again, increase the competition, potentially lower prices. And in the long term, there might be a certain segment which cannot afford to have voluntary insurance. And so then we think about expanding subsidized insurance under PMJAY to those populations. So I'll end with that. Just one thing, sort of this will be, in a sense, a uniquely Indian solution, because the classic textbook tells you that the voluntary health insurance sort of with an informal labor market is extremely difficult. It's very difficult to work anywhere. So what we discuss in terms of building these risk pools, in terms of lowering the prices, will have to be sort of a uniquely Indian solution. There isn't as much global precedent to it. Countries in Southeast Asia, Latin America, China have tried some of this, and it's and there's mixed results. But so I'll also sort of end with that caveat. Thank you. There's few discussion questions, which I think I have on a couple of slides later if you want to get, but that's where I end. Thank you, everyone.
Thank you so much, Anurag, for succinctly summarizing where the current landscape is, how we got here, how this is a uniquely Indian problem and an Indian solution. Before we begin the process of the dialogue, I would first like to hear the thoughts of our other speakers as well. Malti ma'am, I'll hand it over to you for the next few minutes.
Yeah, thank you. And that was a very good, very comprehensive presentation of a very nicely done report, Anurag. And so I think all the key issues have been, kind of raised in that report. It may not be, addressed because as you operationalize something, then the practical issues, on ground issues also emerge. A few points that I would like to make is that the complexity of covering everybody, I think we could be a little less ambitious, that let's cover more people and have a time frame of, let's say, 5 years to achieve that. So maybe then, then we may be a little more, realistic in, what could be achieved and, what could be, done. Voluntary or mandatory, of course, prepaid large pool mandatory is what, everyone would tell us, and every insurer's dream would be to, every person in India is told to buy health insurance. But mandation doesn't happen, even as I was giving example of, motor insurance, even though mandatory and by law required, there are so many vehicles uninsured, particularly the two-wheeler segment or the commercial vehicles. Correct. So I think we will have to look for solutions which are in between, these two extremes of voluntary and mandatory, and how do you increase the uptake? And, provided that we do come up with an affordable product, which every insurer, let's say that, let's imagine for a moment that there was a base product available to every Indian, like a modified version of August' 22, let's say clone of PMJ. I would, for better words, let's say clone of PMJ, because PMJ is very affordable compared to August' 22. If you look at the cost that PMJ is having of the burning cost of the premiums, it's very affordable compared to August' 22. So let's say that if we were to, if Government of India, along with IRDA, along with NHA, was to come up with a standard product like clone of PMJ offered on NHA platform, with all the hospital network, all the packages, health benefit packages. So there is an advantage of there would be an automatic jump start advantage of having so many things in place for a large product, affordable product. Then how do you popularize it? How do you make it get purchased by people for whom health may be a priority after COVID, but they still feel, why I'm healthy, why do I need it? Even richer segments, the young people think like this. So then there is no nothing to be held against people who feel that by the way. So I feel that there have to be a couple of things which could help in addressing this issue. One would be that let's now building an element of OPD is very, very easy, with the digital health coming up, with ABDM coming up, that Ayushman Digital Health Mission coming up. So once we build an OPD element, there would automatically be a greater pull to the product. Hospitalization doesn't attract anyone. I may not fall sick. I may, all those things. Number one. Number two, encouraging people. How do you encourage people? And third would be, how do you avoid adverse selection? So I think adverse selection you could avoid by offering this product to groups only in the beginning. Don't offer it on a retail basis. Don't offer it on individual basis. And groups could be formed for resident welfare association or a maids association, or any informal worker, any kind of groups. But that would be definitely required to subsidize from age to young and healthy to sick. So that groups, that was some concept that we were trying to do in NHA, in missing middle, that only offering it to the groups for safety of adverse selection. Third, making it how do you have the uptake increased. So in this uptake, I would say that if there was let's say that, in India, we are very conscious of the price, and, we are very attracted by free element. There's something available free, sale laga hai, discount ho raha hai, So I think if working on that mindset, if we could offer a, uptake by 20% discount, 30% discount, you enroll within this period, form the groups, I think, and that discount kind of is coming up from the subsidy that the large number would provide. That discount need not be funded by somebody external to the risk pool. The pool itself should fund that discount. Would be that kind of concept. So these are 2 or 3 things at a bigger at a let's say at a what do you say, at a whiteboard kind of a stage. If these 3-4 things are worked out, and I think the NITI Aayog has set up a committee, for looking into the, coming up with solutions for missing middleware insurance industry is a part, IRDA is a part. So I'm sure, we'll have some solutions like this coming up. Yeah. Thank you.
Thank you so much, ma'am. Birendra sir, over to you.
Great presentation, Anurag, and very well articulated by Malti ma'am. Let me say this is a very unique problem of missing middle. Basically, it's basically something which is regulatorily acceptable. When I say regulatory acceptable, the simplicity of the product. It has to be socially desirable, like we say, basically there's a desire from the government, from the insurers, from everybody, there's a desirable out there. It also has to be technological, physical. We have not talked about how do you make the scale of reach of 40 crore families or 40 crore individuals. I mean, in terms of using the technologically doing it. And of course, financially viable for the insurers, because unless until the scale is there and it is financially viable, you see what happened in August' 22. I mean, what basically the numbers were not there in August' 22 as a product. And of course, what Anurag said about in terms of affordability of the customer as well. It has to be equally affordable to the customer or the individuals out there. A lot of things we have done in the past. A lot of innovations and technology work has happened in the past. We can take a lot of cues from that. For example, we used to do a weavers and artisans policy, which is basically social groups. At that point of time, some 17-18 lakhs families were insured, and 3 lakhs roughly around artisans were insured. Now, if you see that product at that point of time, probably in 2010-11, we launched that product. There was a OPD cover. And the product was customized to the requirements of the weavers and artisans. For example, normally weavers and artisans used to have asthma, because they are day in, day out being, with those environment. We had a specific coverage around that, and the sum insured was higher out there. So, similar things happened in RSBY. For example, one of the biggest challenge in RSBY was affordability. Government subsidy was there. And itself, the scale was achieved, and competition led the price from say 1,000 rupees per card to some 300, 400 rupees per card. So, there are multiple ways. The point I want to bring in is this is a segment which may or may not require a subsidy of the government. We'll have to use, there is affordability. We'll have to construct a product which is viable, and then actually use technology and innovation to scale, and then make it affordable rather than being subsidizing and making it affordable. Because anything which is in a subsidy in a long term, 40 crores individuals, honestly, it will be a big challenge for the exchequer for any part of the country. It will be difficult out there. From the insurer's point of view, one of the biggest challenge, of course, is how do you create a large risk pool? Because unless until there is a reduction of the adverse selections, that risk pool will actually absorb the risk out there. And without scale, it will not. The missing middle will always remain missing. How do you ensure that the insurers play a big part, and we create an affordable product and build a scale which then takes care of the product rather than subsidizing those products? I think these are some of the initial thoughts I thought I will share.
Okay, thank you so much.
I would like to make additional point, which I think I missed, is another very important stakeholder in this is the private healthcare providers. Correct. I think taking them along with, because no insurance product, no health insurance product can be viable, can be sustainable, can be feasible without buying it of the private healthcare providers. And making them agree to, because they have a different costing mechanisms. From where the cost is coming? Cost of health insurance is coming basically from the claims cost, the utilization cost. So it's one element is a smaller risk pool, but the other element which is beyond the control of insurance industry is the cost of care. So having a buying in from the private providers at prices or costs which are for, sustainable for them, and helping them, achieve more efficiencies in their own business, having some kind of a, aggregated, purchasing done for them, to bring down their own cost of, inputs is very, very important element where, uh, a collective, work by all the stakeholders, by the, bodies like NHA or, and IRDA and private insurance industry and private providers all have to collectively come and think about it. Yeah.
Correct.
All right, we have quite a few questions lined up, so I will try my best to go through each of them. I think the first one is addressed to Anurag. Mr. Manjunath Shankar has asked, higher OPD fees may be due to increased episodes per annum, or are they due to doctor shopping? Was it controlled for each OPD episode which required admission? You're on mute, Anurag.
Yeah, sorry, can you hear me now?
Yeah.
So this is basically, it doesn't look at whether those OPDs turn into IPDs. You can track that, but this is just to say that these are the number of OPDs and this is what is being spent and these are the number of IPDs. Now, even if you take out the OPDs which turned into IPDs, still the OPD component would be large, right? Because IPDs is only 3 to 4%. So you can add on any amount of OPD, but it wouldn't sort of change that calculus. It's basically like the volume of OPDs and the frequency with which it happens, which drives that number.
Right. The next question we have from Dr. Satish. He has asked, which of the below models in your understanding is the best suited for India? The NHS UK single payer system, the co-pay system that Germany has, or the publicly funded and privately delivered system in Canada, while each has issues, long waiting time, making healthcare delivery more complex. But India needs its own model. What are your thoughts, Malti ma'am, in this?
Anurag, let me take it up.
Yeah, sure.
Yeah. So all we believe is always in India, every unique model. I mean, every point of time, what has held. I mean, let me give some examples. I mean, so that. For example, when we started doing RSBY at that point of time, we thought about doing a cashless card. I mean, today the technology has much evolved. I mean, probably at that point of time, you don't have all those mobile being linked to Jan Dhan accounts and other things. So, I mean, in India, if you ask me, there is a relevant infrastructures from technology point of view, from scale point of view, from digital point of view. We have to use our infrastructure, what is available within our countries and our level of innovations to structure. Probably that will help us to build it faster rather than copying any other models.
All right, I'll move on to the third one.
Very quick point to add
Go
is
ahead.
that,
Sorry to cut you off.
I mean, no, just very, very quickly to add is that in all of these models, I mean, the government spending to GDP ratio is around 8 or 9%. We spend 1.5%, right? So like there is, for any of these models to be successful, there is that gap, or you have to have a very high formal share of the labor market. It's almost 100% or 90% there. We have 10%. So that's where these models sort of break down.
And for us, I think it will have to be an Indian model, and we will have to kind of come up with a Indian model. Is something which is unique, which is frugal, which is takes into account of the complexities of this. We are a huge country, and we have to also take into account, health is a state subject, and between the states there are variations of the health system being at the top or being nowhere. So I think these are the complexities which make one solution. So it will have to be, even within India, we can't have one solution for all types of states. So adopting a country's model, which is presently I sit in Canada and I hear people out, that they are not happy with the system. So I came to a conclusion that nobody's happy with the health system. That maybe that's the truth. In India, we crib about private care and all that. Here, people are cribbing about long waiting periods. Doctors are not available, and COVID has, of course, catapulted lot many issues in the public health systems. So I think no health system we would be able to adopt as it is. We will have to come up, and in fact, it is happening already. We are coming up with our own solutions. You look at the digital health space, I think is one of the most vibrant space in India compared to anywhere, I think, the digital health space, the startups and the solutions that they're coming up with. Yeah.
Thank you, ma'am. Before I move on to the next question in the chat box, actually, Pramesh sir has raised his hand. Sir, I think you've been unmuted. Please go ahead and ask your question.
Yeah, thank you. Thank you, Shivangi. I just have one question for all the panelists. We all speak about how big a country India is, how difficult it is to scale it up. We've had several excuses about how is the basic problem the fact that we spend far too less on public healthcare expenditure, and are we just looking at excuses to avoid this very uncomfortable truth?
Anurag, you want to go first, or?
Sure, I'm happy to either. Look, I would completely agree with you. I mean, no questions asked, right? Our share of spending to our GDP, to our government expenditure is one of the lowest in the world, right? And especially for things which are preventive care, which are public goods, which have a lot of externalities, contact tracing, disease surveillance, and also like for fundamental healthcare, you would need to spend a lot more. So this was sort of framed in the context of if that lever is not moving or not moving fast enough, we inch by 0.1% of the GDP every 2 odd years. But if that's not moving fast enough, then what are some of the other solutions given this how out-of-pocket expenditure burden? But yes, if that happens, that is sort of definitely one of the most.
So there is no denying, that spending on healthcare has to go up. But another harsh fact would be it hasn't gone up, right? So what do you do then? Do we keep on hoping that it will go up, and what would be then, or maybe come up, as Anurag says, solutions that lever doesn't move? What else could be done? I think we have somehow may not be idle, but moved into that space where let's look at solutions. What could be done? With that lever staying where it is and maybe inching, very slowly to make an impact. Otherwise, that would be nothing better than that to happen.
Apologies for interrupting again, but I think if we accept this, I think we are going down a very slippery slope, and we are condemning our society to a situation where it is hopeless and trying to make the best of what we can. I think that's not an acceptable solution.
Okay, so I think I would say that I won't paint a doom scenario because of this. There have been so many learnings, and there have been many learnings. Any program, when RSBY started, people spoke like people said private healthcare, private health insurance is no solution. When PMJ started, people. But I think we also got to admit that people need hospitalization cover. They need primary care. They need public health. They also need, Dr. Indu Bhushan famously, I think one of the interviews he gave, he said, what do you do about people who are getting hospitalized? How do you kind of reduce the shock for them? So it is I won't say that it's a doom scenario, but I would say it's a solution which is implementable in the short run. I would agree that if there was a long-term solution which builds a pathway, connections, and how this seamlessly integrates into a bigger health systems, kind of a situation, that would be really, really good. But I think with all the learnings that we have, with the digital health platforms that we have, with NHA being in place, and a lot of things that are a lot of pieces to the puzzle which are in place, I think we are in better place to kind of embark on this. Private health insurance is actually not looked upon as a solution, and I don't think we are offering it as a solution to what is or whatever be the issues with the health systems at a wider level. But I think it's a solution which is available, which is which is feasible operationally, fiscally, and many ways compared to a long term and I think at my age stage, I have become more realistic. Let's say that.
Right. I'll move on to the next question. Dr. Chintan Maru has asked, transforming the relationship between the payer and provider can be a big driver of affordability. That can be achieved through managed care, value-based purchasing, vertically integrated payer-provider integration, and other models as well. What is the feasibility / timeline on testing some of these options in the Indian context?
Birendra, you want to go first?
Yeah.
Provider relationship.
Yeah. So I mean, as ma'am said earlier, I mean, provider has to be an integral part of this. I mean, there is no way. We can develop a model. To involve a missing model. Middle to be insured. This is a big challenge in terms of payer provider model, in terms of affordability, and but steps are being taken at this point of time, and what it was earlier and currently what steps are being taken by the regulator, by the government. This is a gradual process. It will not happen overnight or other things, but things are being put in place. I think I'm positive about it that in the long run this will be a viable model, because unless this payer provider model is stabilized and it's makes viable for from the affordable point of view, it will be a big challenge. Even the IRDAI has also issued a lot of notifications, regulations around managing this. In the long run, it will fall in place. Ma'am, over to you.
Yeah, I think private provider relationship would never be easy. It would always be pulling each other from the different ends, and so it be. I think that is all right, so long as they have patient's interest in mind, so long as patient and policyholder, whatever you call it, beneficiary, by whatever name, but the person who's receiving care, funding is one is providing and other one is funding. Provided we have the interest of the customer or the patient in mind, there would be a meeting point. I think the meeting point is missing because of many things in India. Like there are no regulations for healthcare. Insurance industry is highly regulated, or that quality of care. There's so many issues surrounding healthcare in India, which is non-standardized. Some of the areas are now getting standardized, and we are having standard treatment guidelines and protocols. But otherwise, there have been many issues. And then I think private care itself has its own challenges of getting talented people, and cost of care, managing efficiencies, and of course they are corporatized. I think we should not forget that. So once the corporatization or any industrialization of a service like healthcare happens, some things are inevitable to happen.
Right. Thank you, ma'am. We'll move on to the next question from Dr. Anjum Sheikh. How about introducing preventive healthcare in the product, which will help to keep population healthy, and this in turn will lead to less outgoing from payers for hospitalization claims, and even private insurers can take part in extending coverage in lower premiums.
That's addressed to me or to whom?
Whoever wants to take it, please.
Virendra, go ahead, please.
Yeah. Preventive care or OPD as a segment. Honestly, many insurers have started launching products around that. But the biggest challenge is how do you link your OPD with your IPD? Till the time there is a direct correlation of OPD leading to lower or IPD, that's a question marks which remain. There have been some successes around there, but eventually, these are things which will lead to do that. One of the other challenges in preventive care or specifically OPD as a segment is that's probably one of the biggest areas of fraud. Even we have seen a lot of the fraud happening OPD much higher in OPD than in even IPD. So a lot of technologies solutions have also evolved in those lines. How do you solve this problem of OPD? That's probably one of the biggest, because IPD you have much more control. The person is hospitalized, you have much more control out there. OPD, there is a challenge of fraud out there, and the scale also. Probably there, if you don't achieve a scale, it becomes inherently difficult to manage. So those are two broad challenges about OPD and preventive care.
Can I add something to another perspective to this? So I think OPD is prone to abuse, because every one of us is anxious to see a doctor at drop of a hat, if we have free access. So I think now with technology available, with teleconsultation being available, telemedicine being available, you can have a layered OPD. You don't expose the whole ecosystem in one go, and then one leads to the other and refers to the other. In that way, but as I said, everyone in the ecosystem has to work together for such an ideal solution to operate efficiently for all, and for this. But I think I'm very confident that this can happen because of the digital infrastructure that we have created and we are creating in the country. So I think that is going to be the backbone of creating this kind of an ecosystem, and for that the foundation is being laid. So that's how I'm pretty confident that OPD can be a very extremely useful solution from the patient perspective also. The anxiety to see a doctor, so you have a helpline, a nurse helpline or something, which leads to then to the consultation, then to the medical test. All those solutions could be actually at least piloted, if not large scale implementation may happen later, but it could be piloted in 1 or 2 districts.
Yeah. Just very quickly to add, when we speak of preventive care, there's also the larger public health element, right? Like a lot of preventive care isn't individual. A lot of it has to do with water and sanitation, things which are beyond the remit of the Ministry of Health per se. It has to do with nutrition. There are extremely strong links between nutrition and health. Yeah, so in that sense, like these are fundamental either public goods or things which have very large positive externalities, which probably the government has to invest in. But yes, within sort of individual insurance, there's all these things which were outlined. So just that framing.
I want to go next to a question being posed by Nipun Virmani. Given group products tend to largely be unprofitable in health, how does one ensure that they are sustainable?
How does one ensure? Sorry, can you just repeat?
Given that group products tend to largely be unprofitable in health, how does one ensure that they are sustainable as well?
So let me answer that, Virendra first, and you can, add if I miss, So group products are unsustainable is a notion that we have in India due to few particular, scenarios that happen, which is basically public sector insurance companies, giving a very wide, luxurious and, no holds barred kind of a cover at a price which is unsustainable. That's what is making the group covers unsustainable. Nothing else is making the group. If you look at the group covers offered by the other insurance companies, it's basically the public sector insurance companies, and we need to bring kind of a, and that's a good question also, that we need to kind of rein in the luxury element or the hoteling element of care, which some of these products tend to offer, and which is making it unaffordable, and then there are elements like covering the parents in the same group, and giving every possible cover on in the cover at a price which is unsustainable. So I think that is what is making it unsustainable. It's not inherently unsustainable. We made it unsustainable by our own wrongful underwriting practices. If we were to do good underwriting, it wouldn't be unsustainable.
So I'll just add to ma'am a few words. Our ability to price group health or group underwriting is.
There seems to be an audio issue with your mic, sir. No.
So I think the point, perhaps if I got, if I could catch the words that he, some of the keywords, the availability of actuarial data is another essential element to pricing of care, So in India, historically, our data collection has not been that strong. And, our in the industry needs, more actuarial data, for pricing of, products correctly. But in groups, I would say that it's less of actuarial pricing, but it's neck to neck the actual utilization versus the premium. So there is very less risk element as such in groups, which we see in the market. It's basically estimating the outgoes, the incidence and the severity, like how many people will fall sick and what will be the severity of that sickness is basically estimating that. Actuarial risk as such, groups I don't think is a risk carrying function. It's more of administrative function, if you ask me.
Anurag, any thoughts? Or we
No,
can
I
move on to
think,
the next question.
yeah.
Okay.
let's-
All right. Yeah, because we have quite a few lined up actually. We'll try to accommodate all of them as best as possible. Is there any thought to go to a deductible plus a no limit system? Surjeet Mandi has asked this.
Sorry, a deductible?
Is there any thought to go to a deductible plus no limit system?
Oh, no limits with any deductible is not a good option in my view, if you ask me. I think you have to, if you have to, like, it's just very simple. You have limited resources. You've got to have some systems to use them judiciously. And unlimited, excess. There are no the doctors are not available, nurses are not available. I mean, there is infrastructure issue, and there is so many issues. So no amount of deductible should be, unlimited cover. What I would say is that, when sometimes people use unlimited, maybe they mean the sum insured may not be limited, So I think that concept is possible, that if you have, sum insured need not be talked about, because if everything like in Ayushman Bharat is covered, but people never reach the limit of 5 lakh, because the way the packages are built, is that people don't, reach the limit except in very rare circumstances. So I think to that extent, for the actual beneficiary, it is unlimited. But how it is being managed at the back end is a very different thing.
All right. Quickly moving on to the next question. Pallav sir has asked, can underutilized schemes such as ESIC and CGHI be used to extend the pool to the missing middle? ESIC, as we know, sits on a huge underutilized amount. This is only seen as an expense by private institutions and employers, and is poorly utilized.
Do you want me to?
Sure.
Yeah, no, I think that's something that we outline in the second part, right? That the possibility of NHA PMJY offering either the existing product or a more sort of PMJ plus product, or of ESIC opening up to voluntary contributory. So that's a possibility. Just the only reason why we shouldn't rush into it is actually the problem that you outlined. With the current system, the utilization is actually very low, which has to do, one, with supply side challenges, but which means that there is the network of the hospitals, the GPs, the clinics that they have, but also a lot of organization and management and governance challenges. So there's a separate sort of ESIC reform agenda. And only, I think, when that has been somewhat reformed, right, where the claims ratio of how much the employers and employees are contributing is actually translating to benefits. Currently, a lot of people who pay ESIC then all have to go and either enroll in private insurance or go to government hospitals, which then basically means you're not paying effectively. So the only concern there is we would want to reform that a little bit before adding more functions onto ESIC and burdening them with a broader mandate. But in principle, yes, in the next 5 years, we should think about it.
All right. Quickly, I want to toss to Deepika had her hand raised. I think you were unmuted, Deepika. Can you go ahead and ask your question, please?
Thank you, Shivangi. This is Dr. Deepika Saraf. Malti ma'am, good evening. How are you?
I'm good, thank you.
So Anurag, your presentation was wonderful. I really liked it. A lot of clarity emerged from it, which I did not have. One of them is like ESIC, the eligibility is, you said 21,000.
Below
so this
that,
is 20, below 21,000 per annum.
Per month.
Per month. Wages, it's wages.
Wages per month. So
Yes.
what is that? What is it for PMJY? I've not till now understood what is it for PMJY, the eligibility. Very simple question, but no answer that I've received till now.
Yes. Okay. So PMJ is an entitlement-based scheme. eligibility is that if you are in that list of deprivation criteria, there are 7 deprivation criteria of SECC, caste census, census 2011, like a kacha hut, no, male member of the family. I'm just giving you a couple of examples. Those are listed. People who are listed as the households which are listed in that list are automatically eligible. So they are automatically eligible. Then there are in the urban settings, there are certain professions, occupational, like maids, drivers, gardeners. The whole issue, Dr. Saraf, is the awareness among these people who have become entitled overnight. So I mean, if 40-50 crore people who are there in that list, there is a data issue, because now it's a 10-year-old census data. So the data itself, has a lot of null household IDs. And then people who are actually there are actually, huge number of them are not aware that they have become entitled to the scheme. So them coming forward and availing benefits is a second challenge. Third, that it's a dynamic data. People keep more people might have moved into poverty, into those category, and some might have moved out of those category. And so the data is not matching up, with the current scenario. So these are some of the issues, but I think who is covered is very clearly defined. And I'll be happy to share the link for that, Yeah.
Now, thank you very much. Thank you very much for this. I will be very happy to go through it. To please try and understand from the user perspective how complicated it may be for a person to come to the scheme, whether he is or she is eligible. After, I have studied statistics, biostatistics, done my doctorate in community medicine from AIIMS. After doing my pediatrics, I have not understood it. Okay, how can you expect a general citizen of India to understand it?
Yeah, so to make it easy, I think the current leadership at NHA and even in the ministry is coming up, like, let's put up a list of people covered at the village level, at the panchayat level. Let's take a print out and put the names of the people. So I mean, there are many ways which are happening. Then there are some missing families, and the state could actually give the names of another vulnerable group instead of if those families are missing. So like that, a lot of effort is happening. I'll be happy to kind of clarify on that on a one-to-one basis.
Please excuse me, ma'am, but this seems more complicated than doing a census.
I think let's connect, Deepika, and of course no solution will be 100%, given the scale and complexities, but whatever is happening, I can definitely share with you. Yeah.
Thank you so much.
All right, thank you. I'm so sorry, we have already actually run over our time limit. Our calls usually extend till 8, but we are very happy and excited to see how many questions we had. Unfortunately, we will not be able to accommodate all. We have taken note of all the remaining questions. If any of you have further questions, please email them to us. The email ID is allhands@firstapp.org. We will be very happy to forward them to our panelists and send back the replies to you. Before we wrap, we have one last announcement. In fact, we have an upcoming health insurance summit from the Confederation of Indian Industries. The theme is Health Insurance in India, Protecting a Billion Indians from Policy to Action. This is a working conference. It's on the 30th of August in Delhi at Le Méridien. Registration link will be provided in the chat box. For further information, you can get in touch with us. Once again, the conference is on the 30th of August. It's in Delhi and it is offline. With that, sadly, we will have to wrap this call. On behalf of Team Swasth, I would like to thank all our speakers for joining us today. Thank you, Anurag, for your presentation. Thank you, Malti ma'am. Thank you, Birendra sir. Thank you for engaging with our attendees so well. The very aim of our all hands call is that we want to foster the constructive exchange of ideas, knowledge, and solutions to pressing healthcare problems. And I think we really managed to do that today. So once again, thank you very much. We will see all of you next month. Do join us. Thank you again.
Thank you.
Thank you. Thanks
Thank
to
you.
all of you.
Thank you all. Thank you.